All right.
This meeting is being recorded.
So today's presentation is in understanding psychosis. One of the main symptoms and syndromes, I would say, we treat at continuum of care is psychosis, and therefore is a super important theme to address in this educational series. For those who don't know me, my name is Rista Luna. I am the family coordinator at Continuum of Care, and I do have quite a long time working on crisis settings and actually experiencing both psychosis at the beginning when people present at the emergency room and inpatient psychiatric settings, and after treatment. I do have a very hopeful view of psychosis, and I do think that with very good interventions, and there are many these days, as well as with early detection, a lot can be done with psychosis, and there are very good medication regimes as well as therapeutic interventions these days that are making a difference in the life of people with psychosis. Um, all right, understanding psychosis. The first thing that we need to understand is the first episode of psychosis. And why is this important? Because the first episode of psychosis is just that, is a sign that there is potentially a mental illness, but we really do not know what that mental illness is. Um, the It typically occurs in adolescent or early adult life. The window for a first episode psychosis is between 16 and 25, um, give or take. I would say psychosis experience before the age of 16 will be early onset and quite rare. And psychosis, first episode of psychosis experience after the age of 25, also very rare, and I would suspect more organic causes at that point than just like the onset of a serious mental illness.
Hi, excuse me, Krista.
Yes.
Would you mind doing a full screen, like a slideshow view? So go up to the slideshow up at the top.
Hold on, I'm gonna stop sharing because I think that's what I'm doing, but I'm not sure what you guys are seeing.
Yeah, we're seeing this stuff on the side. So if you put it on the go back and share it
and show
at the top.
Yeah, there is the start from the beginning, a start show from the first slide.
Yes, I don't think it recognized it if you pressed it last time. Try it again.
All right, here we are. Is it doing it now?
Well, no, you have to share your screen first so I can tell you.
Okay, hold on again. Yeah. And show. Hold on. Sorry about the technical difficulties. Okay, share screen. I'm gonna just share my entire screen, which apparently it doesn't want to do. Okay, great. I'm gonna have to say share window because that's what it wants to share.
Okay.
All right, share. All right, what do we see now?
That's better, but go up to the, I mean, that's sharing, but up at the very top. No, down a little, down one. Yeah, but you could do it that way, I guess.
This way?
Sure.
That's not doing it all.
Go to the right, keep going to the right. Move your, no, move your
file.
No, go over about 4 more.
Slideshow.
Yes, try that. And
from
then
the beginning.
From beginning if you'd like, yes. Now do that.
What do we see now?
See the same thing. I'm not sure why it's not doing what you need it to do.
I'm stopping. Hold on. I'm going to try one more time. see if it does it. And
Hey,
show.
Rista. Hi, it's
Hi.
Claudine. How are
Okay.
you?
I'm doing all right.
I'm loving your webinar. So now what I want you to do is just go down to the bottom of your box here, and there's a green thing that says share screen.
Yes.
Press that,
Share the screen.
and
Okay.
perhaps that.
Yes, no, I did this. So when I do entire screen, let's do share. Okay. Now we're gonna do the slideshow. Can
That's
you see
good.
the
Oh,
slideshow?
okay. Oh, oh.
Okay. All right. Now we're gonna go from the beginning and hope for the best.
There you
Are we
go.
doing? Are we doing it?
Yes, very good.
Then fantastic. Okay.
Wonderful.
All right. Okay. So again, first episode of Psychosis between 16 and 25. If we are talking before 16, likely very rare. But it's called early onset psychosis, and it does happen. If it's over 25, also very rare for the first episode, not for a subsequent episode of psychosis. If the first episode of psychosis happens during adulthood or older adulthood, I will probably request that whoever is assessing my family member, that's also a neurological assessment. Psychosis at later ages can be related to organic causes or dementia. Can be a confusing and traumatic experience for the person and the family, because it's hard to understand what's going on, and sometimes psychosis does not show up bluntly. In other words, it's not like you all of a sudden recognize that the experience of your loved one is not connected to reality. You will want to believe that there is some reality on what they're experiencing. So, if someone tells you that someone is like trying to do them harm or following them, your first impression would be like, maybe that's really happening, right? And only after a series of things that happen, you will realize that that's not connected to reality. Or if someone tells you that they're having some paranormal experience, again, you will tend to believe that maybe that is really happening. And only more evidence will show eventually that this is not the case. And it can cause considerable distress and disruption, because the difference in between the old way to describe mental illness is neurotic illness and psychotic illness. Neurotic being anxiety-based illness, and psychotic illness meaning illness not connected with reality. So in the old way of explaining neurosis versus psychosis, neurotic illness is based in reality. Usually you can counsel someone, give them some advice, try to help them manage their stressors, and that works, right? With psychotic illness, you tell someone that you don't think that what they believe is true, or you try to provide evidence that what they believe or what they're hearing or experiences is not related to reality, and you get nowhere. So it does produce a lot of disruption that way. It also produces disruption because the person that is experiencing psychosis does not believe that is not true. In other words, the person that experiences psychosis believes that that is reality, which means that it will interrupt their work, their school, their family relationships, their love relationships. It might just interrupt all the previous aspects of their development and living. And the more likely treatment will be delayed because of the things that we're talking about, the delay on noticing that this is psychosis, the delay on the person noticing that there is something wrong with them, and the reluctance to accept that this is not reality. The first episode of psychosis has 3 phases: a prodromal phase, an acute phase, and a recovery phase. When we talk about prodromal phase, that can be months of years before you actually notice that there is psychosis. And that's sort of like the more we learn about prodromal phases, the more we can actually understand that there are early signs that can be treated. Even if you don't know if there is going to be psychosis after, you can always start noticing these symptoms and maybe seek professional advice, therapy, seeing a psychiatrist. So symptoms of the prodromal phase: social withdrawal, difficulty with concentration, sleep disturbances, odd behavior, mood changes, anxiety, and deterioration in functioning. This also explains why sometimes people are misdiagnosed, right? If you're having difficulty with concentration, odd behavior, and deterioration in functioning, someone might say, oh, you have ADHD. It looks like it. And the person might even be prescribed an ADHD medication, and that might trigger actually psychotic symptoms, right? Or if the person is socially withdrawn and has sleep disturbances and maybe increased anxiety, a clinician might be like, well, maybe there is some trauma, maybe there is some, these are PTSD symptoms, or maybe there is an anxiety disorder. Maybe this person has OCD, and that's why they have this odd way of thinking. So there is a lot of misdiagnosis in the prodromal phase, which sometimes also delays treatment. The best advice to families is to, as soon as you see or notice some of these symptoms, even if you don't think it's psychosis, if your family member is experiencing these symptoms, seek advice. Even with the misdiagnosis, at least there is someone keeping an eye on them and trying to manage the symptoms, which is ultimately what any healthcare professional will do. Like, diagnosis is important, and at some point we're going to talk about how the diagnosis happens. But more important, you want the symptoms to be managed. You want your family member not to suffer. You want your family member to have the least disruption in life as promptly as possible. The acute symptom of a psychotic episode is when you can see the person being psychotic. So this is when you're like calling a provider, you're calling the emergency room, you're talking to the PCP and telling someone, this is not right, my family member is not doing well. These are usually positive symptoms, and we'll also go into detail in a little bit. But think about positive symptoms, compare them to positive numbers. So when you talk about positive numbers, there is a plus in front of the number. Positive symptoms have a plus in front of the symptom. So what you observe when you have positive symptoms is increased thinking, right? Racing thoughts. You have increased energy, increased perception. You perceive things that are not there. You hear voices, you see things, like plus something. Those will be the positive symptoms. And that's why we notice, because positive symptoms are noticeable. And then there is the recovery phase. And the recovery phase is super important. And sometimes we don't realize what's going on during this phase. And we're like, my family member is supposed to be well. Why is my family member not well? In the recovery phase, most of the positive symptoms, especially, are gone. However, sometimes there is a gradual dissipation of what we call negative symptoms, and we'll go into that. And negative doesn't mean bad. Negative in this case means minus. So it's very common that someone recovering from an episode of psychosis, right after they have psychosis, will experience this, again, minus, or this negative symptoms. And negative symptoms are decreased energy, decreased motivation, decreased concentration, decreased socialization. Think minus anything. And sometimes those symptoms end up being more impairing than the more obvious, grandiose, noticeable symptoms of psychosis. No, sorry, I am going to go back. Okay, here we are. Sorry about this.
Krista, you might want
here, I am.
questions.
Okay.
Can you see in the chat? A couple of questions in the chat.
Okay. If people doesn't mind, I will probably answer the questions at the end of the presentation. I'll make sure to have some time for that. Mostly also because I have to go back and forth and I can't see right now the chat with the presentation on my screen. Um, so anyway, why is it important to treat early? Again, better outcomes, better services, um, and there is a preservation of some basic skills. Um, think about psychosis as a brain deteriorating disease. To a certain extent, the more episodes of psychosis, the more difficult recovery is. If you intervene early and you avoid future episodes of psychosis, you prevent that brain from um, deteriorating more. And the most important thing is that early intervention addresses those negative symptoms, which we sometimes don't notice or we don't think are important, but they're probably the most crippling symptoms in terms of psychotic illness. If there is early intervention in residential care with connections, with family support, clients might be able to avoid getting into this cycle of like being amotivated, not wanting to do anything, only doing certain things that they like, but not the others, abandoning interests that they had before, abandoning relationships that they had before. These very behavioral interventions, and there is a main intervention called PCBT. It's a CBT for psychosis. There is also community integration. It's a great way to address this lack of, or again, negative symptoms. Case management, psychotherapy, supported employment and education, all of these things help the client continue to be involved in their community, in their family, in their life ultimately. So definitely important to treat early and to never stop treating and to pay attention to those negative symptoms. Again, this is, oops, where were you? Okay. Positive symptoms, hallucinations. Those are experiencing perceptual experiences that are not true, seeing things that are not there, hearing things that are not there. Delusion, thinking things that are not real. There have very different themes. And remember, we are thinking, it says here positive symptoms of schizophrenia, but these are positive symptoms of psychosis. They could be associated with other disorders. The key with delusions, and they can also give you some diagnostic cues, is the delusions are usually associated with the disorder. So, for example, someone that has depression might have very sad delusions, very negative delusions, what they call nihilistic delusions. So typically someone that is depressed and having delusions might think I am destitute, I have no money, I lost everything, or no one, my family doesn't love me and they're going to leave me. I mean, we can all feel sometimes that no one loves us when we're like sad, but in this case, let's say a very depressed mom might think, no, my wife is going to pack and leave. Like I know she is. So it becomes not connected with reality. So again, a depressed person will have sad delusions, very depressed, negative delusions. A manic person, when you're talking about bipolar illness, will have very grandiose, happy delusions, right? These are the people that are going to be the next Soros, or they're going to create a flying car, or they're going to open a business and make millions, or they're think about all these grandiose delusions that if you've had anyone with that has been very elevated of manic has said. Also, very, I'm going to say the word, if there is a religious component, that's where people tend to believe that they're like some sort of religious figure reincarnated or things like that. Again, if you're elevated, your delusions are elevated. And then schizophrenia, which is a thought disorder, will be very disorganized delusions that are just not possible, right? So think about delusions that have to do with, all the people being lizard people, or, very like you will notice. So if someone tells you a disorganized delusion, you'll notice that it's a delusion because it's highly not likely. Again, that's the difference in between the delusions associated with a mood disorder and the delusions associated with a thought disorder. The delusions associated with a mood disorder, you might be like, well, like with the wife thing, like maybe she's gonna leave because he's like so sad, right? But again, I can read your mind, and I know what you're thinking. It's probably not true. So think about more disorganized delusions with schizophrenia, more grandiose delusions with mania, more very sad, depressive delusions with depression. Disorganized thinking, that's also part of the positive symptoms. A lot of people that has psychosis, especially when it's not medicated, and that might be one of the first things you notice, they have this thing called word salad, right? Or they have tangential thinking. So that is all disorganized thinking. Some people will, basically jump from one team to the other. I see butterflies fly. I want a plane because my mother went to France. That will be a sentence, a psychotic sentence. It just doesn't make sense, and it goes from one team to the other. Maybe there is a connection, but you will have a very hard time figuring out that connection. And abnormal motor behavior refers to agitation. Usually you'll see pacing, you'll see people talking to themselves, you'll see people smiling or inappropriate, incongruent with mood, right? Smiling when there's nothing funny, or crying when there's nothing to be crying about, or crying when you just told them a joke. So again, abnormal behavior, not congruent what's really going on. And then we have the negative symptoms. Negative symptoms, as I said, decrease of anything. Affective deficit, meaning people, it says here lack of facial expression, but also people has a hard time recognizing what they're feeling. It's very common that someone coming off a psychotic episode, if you ask them, how are you feeling? They'll be like, I don't know. Are you upset? Nope. Are you happy? Nope. There's just no recognition of feeling. Even if they're laughing or crying, they might be like, I don't know. And then communicative deficits, that's called poverty of speech. So if someone was very fluent before, you might notice that the person has a difficulty having conversations or respond in very monosyllabic ways, or cannot follow your conversation. You might think that there's something wrong with them cognitively. There is, again, poverty of speech. Relational deficits, we spoke about that. A lot less desire to socialize. This is typically when you have complaints about, like, why is my family member playing video games all the time and not socializing with anyone, or refusing to attend family events, or spending most of the time in the room. Again, those would be the relational deficits. And avolition means I don't have the will to do anything. So if I before was going to college and working, I might not want to do either. If I before was interested in relationships, I might not have any investment on that. Just lack of motivation. I think we spoke about the psychosis can affect basically all areas of the person's life, from employment, school, relationships, physical health. Remember, avolition and anergia can affect the ability or willingness to the people to take care of themselves, right? Like, if I don't feel like doing anything, why am I going to get out of bed? Why am I going to take a shower? Why am I going to brush my teeth? Why am I going to eat healthy? Why am I going to cook for myself? And that obviously decreases physical health. Part of the early interventions and part of the community integration interventions that we do here, but are recommended in the literature in general, is exercise, nutritional interventions, meal planning, all those things that preserve basic, what we call activities of daily living or daily living skills. Obviously, it can result in criminal justice issues. Psychosis, psychotic people sometimes believe things that are not true. I mean, and most psychotic people, actually, there is this sort of ill belief or this incorrect belief that psychotic people tend to be violent. Most of the charges that psychotic people get are for silly things, not really for violence, right? Like, if they believe that there is a treasure in a house, they might have they might be looking for the treasure and get charges for trespassing. If they're running away from someone, they might get, reckless driving because they were like driving, speeding because they thought they were being chased. So a lot of the charges that people in the midst of psychosis get are, pretty severe, but also not necessarily because of violence. I think there's some statistics that say that only 1% of psychotic people acts out on violent ideation. So it's very minimal. It can be scary, and a lot of psychotic people will tell us a lot of things that sound scary, but it's really most of the time, the trouble that they get into, it's because of the disconnection with reality than anything else. Increases utilization of emergency rooms, especially when they're in the prodromal phase and no one knows what's going on. So emergency rooms will tell you, as some of you might experience, there's nothing wrong with him, take him home, and then the next day you're there again. So that's also something that the system should address probably. Need for long-term care, especially if the psychosis is untreated. Recovery from psychosis is a gradual process and unique to each person. That's important to know because, it's not a 7-day hospitalization. There is follow-up after the initial stabilization of medication. Medications are important, they're crucial, they, again, save brains, but they're not all that needs to be done, because once you've controlled with medication the positive symptoms, you do have to have a lot of psychosocial therapeutic interventions to manage those negative symptoms. And the better those negative symptoms are managed, the more chances that the person will not relapse, that the person will stay well. So that's very important to know. Effective strategies, shared decision making. Sometimes it's good, and I would say recommended, to talk to your loved one when they're well, when they're not in the midst of a psychotic episode, so that they can allow you to make decisions for them when they're not well. Think about making a decision about admitting to the hospital, making a decision about where they're transferred, making a decision about what medications to take and what route to take them. All of those things are possible if they give you, conservatorship or power of attorney, mental health power of attorney. That might help them make decisions, when they can make decisions, that they can tell you in advance what would be their preference, and you can advocate for that. Harm reduction, that is very important. My summary of harm reduction: some treatment, better than no treatment. So even if you think your family member needs, a year of treatment, if they agree to 1 month, that's a good thing. Take it, right? Even if you think your family member needs 3 medications and they agree to 1 medication, that is good. They're taking a medication. Harm reduction is actually probably the best approach to manage any illness, but particularly psychotic illness, because it allows for clients to stay connected to services, to slowly come to terms. It's very hard to accept that you have a chronic mental illness. I mean, it's no different than, being diagnosed with diabetes or heart disease or something that you have to take care, the rest of your life. And normally, think about how many of us get, to be on cholesterol pills or blood pressure pills in our 40s or 50s. These young people are usually being told something worse than that. You're going to have to be on this medication for the rest of your life when they're like in their 20s. So it is hard. It requires a period of acceptance, and it requires a period of grieving, right? Grieving who I was before and accepting who I am now. And in this case, harm reduction, also motivational interviewing, it's the clinical term, just meeting people where they're at. It's very important. But again, summary, some treatment better than no treatment. And again, it says here, families should be considered and are an important part of the care team. I was reading just some statistics before this presentation. About 50% of the people with serious mental illness lives with family. Only 10% of families receive any kind of support of education. That is something that needs to change in the landscape of mental health treatment. Families do need to be involved. They do need education. They do need support as well. If we know that most of these families, most of us, have a family member with a mental illness that will be living with us or will be in close contact with us, right? And will be asking us to be their power of attorney or their conservator so we can advocate for them. So family services extremely necessary. Medication, again, brain saving, essential for managing, especially positive symptoms. Neuropsych testing, that is one way to find out what's really going on in terms of diagnosis. I would recommend that, again, if you look at that threshold from between 16 and 25, I would recommend that you do repeat neuropsych testing at the end of the threshold. In other words, you might have different diagnoses or different opinions and different results when your kid's 16, maybe 20. You should probably retest or get a good diagnostic profile when they're in their late 20s, so that you can see really what the most likely final definite diagnosis is. And remaining active, like I said, it's the best way to combat, to manage negative symptoms. One of the techniques that it's used in PCBT is actually called behavioral activation. It's just that. Let's make sure that behaviorally, even if you don't want to, even if you think that you're not going to like it, behaviorally you activate yourself. You do things, and in the doing, in the routine, in the structure is where these clients find their way through those negative symptoms. Okay, next. Here are a bunch of slide resources that I will be sending over to you. There is a lot of resources for serious mental illness, especially for first episode psychosis, resources for families, a lot of things online, a lot of reading material. And again, I'll be sending all of these to you. And now I am gonna stop sharing and look at the questions and hope that this works. Sorry about this. Where are we? Here we are. Okay, beautiful. I'm gonna go in the chat and start with the questions. So, all right. Can you make the slides full? Yes, we did that already. All right, Liz, we're talking about someone else. How does anyone know when there is a first experience? That is a good question. It's hard because the first episode of psychosis starts with the prodromal phase, and the prodromal phase is not frank psychosis. I would say if anyone during this threshold, 16 to 25, that is being a certain way, looks different to you as a family member, and has social isolation, odd thinking, racing thoughts, difficulty concentrating, changes in functioning, that you do your due diligence and get at least a psychiatric assessment, an outpatient psychiatric assessment. At that point, they're probably not doing anything that will warrant a visit to the emergency room, but a visit to someone that can say, this looks prodromal, or, even again, even if they misdiagnose, if they can at least treat the symptoms, they're protecting that brain. Because remember, that's what you want to do. You want to protect that brain. If the symptoms do not settle and do not take over that brain has a better chance. And then we have Sarah. What can be done, or is there hope if we are past the first episode? Yes, there is hope if we're past the first episode. Intervene when you can. I would say the first thing to do is to stabilize the positive symptoms. And that it's mostly done with medication management. Once the positive symptoms are stabilized, and that's, again, I would say a third of the battle, important, but a third of the battle, then you can work with the client. Positive symptoms are not connected to reality, so it's hard to talk to someone that it's not connected to reality. Once those symptoms are addressed, then you can start the other interventions. And again, the research shows that not managing negative symptoms is what causes relapse. So once you manage the positive symptoms and you know now that you have to intervene with the negative symptoms, then you can intervene in a more sort of comprehensive way. And comprehensive, I mean, again, negative symptoms affect everything, right? From going to the PCP and getting a good physical, making sure that we're taking our vitamins, and making sure that we are, we don't have any medical things going on, especially if this is not the first episode. If it's not the first episode, maybe we gotta go to the dentist because we haven't been brushing our teeth. Maybe we need to, again, start taking some vitamins because we've been neglecting our nutrition. So starting from that, once the positive symptoms are managed, that will be important. Managing psychosocially, what's going on with your family member, right? Is my family member socializing? They're not. What are the resources? Are they social clubs in the community? Are they, again, if you're religious or affiliated to any kind of church, like are there any groups that they can attend in church, and anything that can get, any hobbies that they might, community college sometimes have non-credit classes that people can take. Anything that can get them out of the house and get them to socialize. And this is why, like, sometimes community integration systems or community integration program, it's so important for clients coming off of any kind of episode of psychosis, because then you don't have to be the case manager. Think case management services, either on a residential level or on an outpatient level, allow you to be the mom, allow you to be the dad, allow you to be the family, and the case manager can do the, like, do you want to go here kind of thing? Do you want to do this? Let's register you for this, and you can just assume your role. So case managers services are also important. And then again, think about holistically what does a person need and what things are neglected when negative symptoms affect. All of those things should be addressed at any time, really. And that would be my hope. I've seen people come to our program, the one that I work now at, and to prior programs that I worked before, affected sometimes by, this was the third, fourth time affected by an episode of psychosis. And they, once they get the community integration services, they do well. Yes, there is some limitations associated with, again, prolonged illness that has not been treated, but most people get to live a full life. And there's an episode of mourning and an episode of adaptation, because you might have to, like, now think about, reoriented your career, finding a new girlfriend, because you did lose certain things. But what you lost is not necessarily what you can not gain in the future. Full lives are really possible once there is a holistic approach after, again, positive symptoms are addressed. Another question says, what do you think about the Hearing Voices Network support groups? Um, Actually, I do like them. I do like them a lot because I think that in general, like a lot of what's going on right now in terms of research and in terms of support for people in the community um, is peer support. And peer support is beautiful because as an expert and a psychiatrist can tell you that you should take your medication. I can do PCVD to beat people until I die, and use other techniques. I can like be a cheerleader for community integration, and yet I have not had the experience that my clients have had. And I think it's super valuable that they hear from other people how they cope, what they've done, how are they successful, how they deal with their illness every day. And it's any kind of support group. And there is the Hearing Voices support group. There is NAMI support groups for parents like you. There's support groups for bipolar illness. There's a number of support groups that again provide that peer support that none of us can provide for your family member. The other thing that is happening a lot in community integration programs, both at the inpatient, residential, and outpatient level, is that now these peers are being employed as part of the staff in the programs. And why is this important? Again, because when you're coming to a place or when you're starting treatment and you see someone, the white coat sort of fear, someone that looks like a professional, looks like a doctor, they don't feel that comfortable, right? But when you see someone that looks like you and can tell you, no, I was here, I did this before, and it's okay. That makes a whole lot of a difference. I went to a recent conference in Austin, and it was a crisis residential conference. And one of the keynote speakers was someone older man, probably on his 50s, 60s, that had been his first experience with mental illness was him being a patient, and now he runs a network of crisis houses in New York State, actually, and he experienced it. He reports his experience as how he started, sort of running these crisis services in New York was by him wanting to volunteer at the same emergency room that he had been admitted involuntarily through. And he was able to basically chat with the people that didn't want to chat with anyone because he had been there and he knew what they were going through. So just an example of how peer supports are super valuable. And there's a lot of evidence-based research that says that needs to be supported, funded, etc. Okay, then we have another question. Okay, we are on our 7th year of our son's illness, diagnosed in 2019, schizoaffective disorder. Most important was to get his acceptance of meds. Yes, and become stable on them. This took 5 years. Yes, I hear you. He is now on a 3-month injectable. That is good to hear. And mood stabilizer. It was a continuing program which started him on his path of accepting meds, and we're forever grateful. Absolutely. First of all, thanks for the continued shout out, but more importantly, a 3-month injectable, it's probably one of the best ways to manage psychotic illness. Think about having to make the decision about taking medication every day if you're taking oral medication. When you're psychotic and you have to be ruminating on accepting your illness every day or twice a day, it's really, really hard. If you only have to make that decision once a month or once every 3 months, life becomes super easy. You can do more things, you can go to school, you can do things, you don't have to worry about missing your meds. Mom and dad don't have to worry about, it's he or she gonna remember to take meds. because they only have to remember to go to their doctor or nurse appointment every so often. So yes, long-acting injectables are definitely a great option. In and sometimes selling the long-acting injectables is takes time, but definitely something that is worth doing. And again, just think about all these medications as brain-saving medications. And yes, also NAMI Family to Family, absolutely very good program. You can enroll online, and there is it's a large community of parents. Really worth doing it. So I don't know if anyone else has any other questions. We do have still a couple of minutes. As always, I will be sending a copy of this presentation, the links to the resources, as well as some written material that I have. So again, if anyone has any other questions.
I just wanted to mention, I'm sorry, Krista, just wanted you to mention that your next webinar is Wednesday, January 25th.
Yep, and it'll be on co-occurring disorders, which is another very popular theme, especially among our own consumers at Continuum. So look forward to seeing you all. And yes, thanks, Sarah, and thanks everyone for being here, and happy to answer more questions. We'll be here. Bye-bye.